Hello, everyone. My name is Linda Robinson. Many of you probably know me. If you do not, I'm an HIV pharmacotherapy specialist, and I have been brought on board from CHAP to share with you a three-part learning series. Now, just bear with me for a moment while I get myself set up, because we are going to start with part one of our series momentarily. Just going to share my screen here. Okay, give me 1 second. And we should be all looking at the same thing very soon. Okay. I'm hoping you are seeing what I am seeing now, and that would be the title page. So again, hi to everybody. In the next 30 minutes, I'm going to be presenting to you the first of a three-part series that I call Tackling Antiretroviral Therapy Resistance, or the Management of Treatment-Experienced Virus. I would also like to call this How to Become an Expert Antiretroviral Resistance Interpreter in 90 minutes or less. So let's get started on our first 30-minute session. But before we get started, here's my mandatory disclosure slide. As you can see, I am very impartial, and when it comes to education, I'm all for it, and I will take on any gig where I can help create educational pieces, or I can be consulted on HIV education, or I can talk about it. I am all for it, but it's important to note in this particular three-part session, the opinions and the format of the entire module are only my own. I'm only going to be offering you some hints and strategies that I've learned throughout my 30 plus years career as an HIV pharmacotherapy specialist. And I am hoping that I will share some of those with you. It was supported by an unrestricted educational grant through CHAP education projects, but this particular three-part module received funding, especially from Merck, so I'd like to thank them for that. They had no part, nor did anybody in CHAP or other companies have anything to say about the content of this particular educational piece. So these are going to be our learning objectives for this exercise. In our first segment, we're going to learn how and why antiretroviral resistance develops and how this resistance is measured and reported. In part two, we're going to use a case example of how anyone can become an expert sleuth in uncovering and interpreting ART resistance mutations, as I introduce you to algorithmic tools that we use in creating optimized, durable antiretroviral therapy regimens. And finally, in part three, we're going to go into a little more depth with regards to certain mutations and resistance pathways in order to help you make predictions in cases where resistance data might either be missing or incomplete. So whether you are new to the world of HIV infection and its management, or you have been doing this for as long as I have, my overarching goal is to provide a few tricks and tips that may make you feel more confident in the understanding of ART resistance and therefore applying it to making treatment decisions. And this is whether you are the teacher or you are the learner. So thank you for joining me, and let's get started. Before we begin, I think it's important that we understand where we have come from with HIV treatment and where we are going in terms of modern treatment regimens. Let's look at, first of all, how the definition of modern antiretroviral therapy has changed over time. At the left of this slide, what was modern in 1995 was life-saving triple therapy. However, these early triple drug regimens were made up of handfuls of pills, taken multiple times during the day, often affected by or culprits of drug interactions, and usually were comprised of drugs that, unless you took them 95% of the time faithfully, they achieved insufficient drug levels to keep the virus completely suppressed. Flash forward 10 years to 2015, and modern ART was now defined as convenient, meaning that our first single tablet triple drug regimens hit the market and were taken only once a day. Huge breakthrough. But unfortunately, a lot of the earlier models of these were comprised of non-nucleoside reverse transcriptase or first-generation integrase backbones with lower genetic barriers to resistance. Within the last 10 years of ARV development, we've made some huge strides, and we have had access now not to long-acting single tablet regimens that have incredibly improved pharmacokinetics and have second generation integrase inhibitors or second generation protease inhibitors as their backbones. And more recently, we have even had some access to long-acting injectable medications and some two-drug regimens as well. So let's just keep that in mind as we go forward. And this is to show us that in another year's time, we might even be looking at oral regimens that consist of only two long-acting agents that can be taken only once a week. Or maybe even if we really look into the crystal ball, we might be seeing some antiretroviral regimens long-acting enough to only be taken with an injection either every 4 or 6 months, either IM or subcutaneously. So the bottom line is the pipeline is always active in HIV. And the reason for that is we keep giving medications to a virus. A virus sees the medication, sometimes, if not in enough concentration, and develops resistance to it. So, although we are saving lives and the pluses of taking antiretroviral therapy far outweigh any of these negatives, we need to constantly be making new medications to help us overcome these resistance, the development of resistance. So at the turn of the century, in the early 2000s, our goals were basically get on treatment and it will increase your lifespan and decrease the risk of AIDS and non-AIDS conditions. And we tried to not let the immune system become too depleted before starting therapy, but we often left HIV kind of unchecked, waiting till the CD4 count dropped to like 350 before we started medications. And then when we did start medications, we often used those earlier regimens that weren't very potent. Um, so the key point here is a lot of these plans, treatment plans, and the drugs themselves that were used back in the day could have led to poor and inconsistent virologic suppression. That is the perfect milieu for the development of antiretroviral resistance. Now, that is not our treatment approaches today, of course. Modern treatment now will normalize a person's lifespan and virtually eliminate the risk of AIDS and non-AIDS conditions. And the earlier this medication is started, the better, regardless of what their viral load or their immune status is. So, simple and durable is the best option for not just the ART regimen longevity, but the patient longevity as well. So it's important that we understand this is where we're going forward. Why does that matter? Well, it's pretty clear as to when and how we start therapy, but when and why would we change therapy? And there's basically three main reasons. Number one, when it's no longer working. That basically means that there's been a viral breakthrough, a detectable viral load that has been affirmed with a second measure at least, and that means that that particular regimen for some reason is not suppressing the virus anymore, and could mean that there's a resistant population breaking through. The second reason we might want to change therapy is if the patient wants to change the therapy. And then we'll talk about reasons why this might be the case. It's very important to engage our patients and keep them engaged because that helps you and them stay focused on therapy, stay adherent to their regimens, and therefore reduce the risk of resistance developing. And then also, when something better comes along, it's kind of our duty as clinicians to let people become aware of these things and see if they want to give something newer and improved a try. So it's our duty to make sure that they become aware of these things. So, what would be some of the reasons we might want to simplify or modernize a regimen in the case of where the virus is suppressed? Well, we might want to decrease pill burden. We might want to simplify dosing times. We might want to reduce side effects. We might want to avoid some drug interactions. We might want to help the patient with some cost savings or some programs that may help offset some of their out-of-pocket costs for medications. So there are many reasons why we might want to simplify or modernize regimen. So to sum things up, the original goals for HIV treatment, and to this day still exist, are maximal and durable suppression of viral load, restoration and preservation of the immunological function, or the CD4 count we want to improve, reduction of HIV-related morbidity and mortality, and obviously an improvement of quality of life. In modern times, our goals of therapy have also evolved to consist of these. We want to prevent transmission of HIV. So having a completely undetectable viral load, it means that somebody is incapable of transmitting the virus. U equals U, undetectable equals untransmittable. So not only is it for the benefit of of the patient to be on their own medication, but it is also to the benefit of others who may come in contact with this particular patient in some high risk situation, behavioral situations, and it will prevent the transmission of HIV if they are undetectable. We also have the goal of engagement and re-engagement of the patients because we get them on therapy sooner, as soon as possible, and keep them on it for for a lifetime, as far as we know today. So we want to keep them engaged and we want to keep them re-engaged. We also want them to be on something for a long period of time that is safe and durable and easy to take. So these are what would be more of our modern goals of treatment. So now we got to move on and take a look at how existing or archived resistance or the potential of antiretroviral therapy resistance developing must play a role when we make these modern treatment decisions. And that takes us to our first learning objective, number one, and that is the why and the how of development of antiretroviral resistance. So let's start with a few basic definitions. There are two main types of antiretroviral resistance that we are constantly updating guidelines to help us understand trends and management for. Primary resistance or transmitted resistance is the type of resistance which occurs when the virus that is transmitted upon infection is not wild type virus, but a mutated antiretroviral resistant quasi-species of HIV. The reason why baseline genotypes are suggested in all major guidelines pertaining to the management of a new diagnosis of HIV is exactly so this type of resistance can be detected. And even though the prevalence of transmitted resistance is low, it should still be taken into account when making our first treatment decisions. As a matter of fact, transmitted resistance may become a bit more important as we roll out PrEP on a larger scale, because if someone on PrEP presents with a new HIV infection that they got while taking PrEP, they may have been infected with a resistant form of the virus that was resisting the PrEP. So we definitely will have to keep doing these baseline genotypes on new diagnoses. But the second and most common and familiar type of resistance is called acquired resistance. Acquired resistance is basically means that a quasi-species or a mutant strain of HIV evolves as the dominant strain under suboptimal antiretroviral pressure. So this is the type of resistance that for the greater part of this three-part module, we are going to be spending our time working on. So let's go back to some basics. What is the postulated theory behind the development or acquisition of antiretroviral resistance? So we're going to spend a few minutes now looking at this schematically. When wild-type HIV1, shown on this slide, the bottom corner of this slide, when wild-type HIV1 replicates, it is estimated that 10 billion copies per day is possible. Approximately 1% of those virions, or 100,000 per day, have a mutation somewhere in the genome. I've represented that schematically here by coloring some of the viruses, yellow and blue, etc. They represent mutant forms and not same parent as the parent virus. Why does this happen? Well, this occurs because HIV reverse transcriptase, the first enzyme that's really actively involved in the replication cycle of HIV, is a sloppy enzyme, and it lacks the ability to go back and proofread what it has done when it comes to sequencing. So some of these mutations just naturally happen, but this occurs because, again, it's a sloppy enzyme. And some of these quasi-species or non-wild type species are capable of replication and some are not. But when we initiate antiretroviral therapy, as I have done here, the ultimate goal is to suppress replication of the virus as much as absolutely possible, so that the chance of developing these random mutations is even more severely lessened. That 1% becomes even more inconsequential. The virus, however, still does undergo some low-level replication, and over time, we'll realize that certain quasi-species will replicate in the presence of drug. If the drug pressure is not heavy enough or maintained at a sufficient level to completely suppress viral replication, these quasi-species or less replicatively fit versions of the virus will become the dominant species. I've shown you the yellow mutant now realizing an example and now becoming the dominant species when there's not enough drug pressure on board for that mutant to stay suppressed. Little bit of drug, a little bit of virus growing back, bad combination. And we're going to talk more about that in a little bit, okay? So it is going to become the dominant species and will be detected in the plasma as a breakthrough in the viral load. Basic Darwinian principles apply here, and it becomes a survival of the fittest scenario. The wild-type species will always be the hardiest form of the virus and the best equipped with the best machinery for continuing the species. Keep in mind, however, the mutant virus, though capable of continuing the species, does so less effectively, sacrifices some fitness, we say. Thus, if we take away all the drug pressure, over time, the population will eventually return to the most fit or wild-type form of the virus. How much time this takes when therapy is stopped varies, depending upon the mutation. Some PI-resistant variants can be detected using resistance assays years after stopping that PI. But what is really important to remember, however, is that resistant virions can become latent and therefore archived and not always picked up on the next genotype. Just like wild-type virus, they never really go away. So detectable or not, they have the chance of becoming the fit population once again in a certain drug environment. So, as a quick recap, it is poor drug pressure that allows a little bit of virus to grow enough to realize an advantage to become the dominant population in a certain low drug concentration milieu. And this is when or how resistance develops. Once it's developed, once it is there, it never goes away, whether or not you see it on genotypes. And we're going to learn a lot more about that as we keep going. In the meantime, let's define what poor drug pressure means. So there are many reasons why we may not have enough pressure from the drug therapy. Pharmacokinetically, the drugs may not be absorbed, for example, because of drug interactions with food or other drugs, or maybe the stomach is not acidic or alkaline enough for the drugs to actually be absorbed properly. Drug interactions involving metabolism, involving the cytochrome P450 system, for example, may lead to insufficient drug levels of either the antiretroviral drug or the drug that it is interacting with. So this can also be a reason why we don't have good drug pressure for viral suppression. Poor drug pressure may also be a result of the body's inability to distribute the drugs to the active compartments, i.e. glycoprotein inhibition with protease inhibitors, or maybe we're over excretion of a medication is happening because it is competing with another drug for excretion. These may all be the pharmacokinetic reasons why the drug is not applying enough pressure. Okay. So it's important to know that sometimes dosing isn't correct. Sometimes the drug pressure is inadequate because the antiretroviral regimen chosen consists of medications that either should not be used together or require dosage adjustments when they are used together. So this was more of a problem with some of our earlier antiretroviral therapy, which many were considered to have a lower genetic barrier to resistance. So again, a longer term treated patient may have this issue more than somebody in more modern days. So what I do want to talk about a little bit here is the genetic barrier to resistance. So what do we mean by that? This can be defined simply as how well a drug sort of fits and locks into its site of action and resists getting bumped out, so to speak. Or it can also be defined as the number of mutations that are required before the drug is bumped out and the viral replication can continue. Okay? I'm going to talk more about this as we move forward, but the concept of genetic barrier will become clearer as we continue these modules. But for now, I think we need to briefly visit the most common and obvious cause of inadequate drug pressure, and that being poor adherence. In an older and landmark publication, Bansberg and Sethi, and more recently Harrigan from BC and others, have described the relationship between adherence, antiviral activity, and the risk of resistance developing as follows in this particular slide using this bell-shaped curve. If we could graph the risk of developing resistance against increasing adherence, this is what we would see. From zero adherence to approximately 70% adherence, there is a lower risk of developing resistance. Why? Because there's not enough consistent drug pressure at all to sustain poorly fit or mutant virus. The virus population here will most likely be predominantly wild type because this will be the most favorable always form of the virus to replicate. In other words, there would be no need for the viral population to sacrifice fitness and the wild type virus would prevail. This may be why a genotype report on a viral sample that's taken when someone has been off their meds for a while will show no resistance. And that's because of this reversion back to wild type, because there's no pressure to force out mutant populations. Let's look at the other end of the scale, where adherence approaches near perfect. Again, we have a green zone with a very low risk of resistance developing. And that's because in this scenario, with complete viral suppression, though there may be very low level replication going on, the virus is sufficiently suppressed so that there's little chance for a mutant population to take over. Where the problem lies is in the 75 to 90% adherence range, shown here in red. This is where we see the highest risk of resistance developing. It is in this danger zone that the drug pressure on the virus is not enough to completely suppress replication, but just enough to allow the viral quasi-species or mutants that can live under this drug pressure to evolve as the dominant species. What does 75% adherence look like? Well, it means missing 6 to 12 doses a month or 2 doses per week. So the patients who we may classify as pretty good drug takers may be at significant risk of developing antiretroviral resistance, depending on the regimen. Now, I cannot move in modern times with a resistance talk without talking about what I call the forgiveness factor. In these modern times, our regimens have been improved so that there may be a bit of forgiveness of missed doses built into the regimen itself, making adherence a little less strict than it may have been in the early part of the 2000s. Recently, it was shown by a group in Italy that a triple drug regimen with a second generation high genetic barrier to resistant integrase backbone did not really start to lose the ability to suppress the virus until adherence dropped below 70%. Another study showed that taking bictegravir combined with tenofovir alafenamide and emtricitabine 4 times weekly after virus had been suppressed was probably enough. A similar study did not show that that was okay with 2 drugs. We still tend to lose some of the ability to suppress virus in 2 drug regimens a little bit sooner than at the 70 or 65% mark. Okay? But at the end of the day, what matters most is we don't tell patients it's okay to take your pills 4 times a week. What matters most is we counsel them to take their meds faithfully as prescribed. The forgiveness factor should only come into play if the patient divulges that they are missing the odd dose. Adherence is a lifelong behavior. Taking drugs is a behavior, like quitting smoking, quitting alcohol, sticking to a diet, sticking to taking medications. This is a behavior. And the better we can cancel patients on how to fit these meds into their routine, the more we can encourage this becoming a lifelong behavior. So we never tell them the forgiveness factor unless we have to put their mind at ease. All right. One other thing that can, a couple of other things that can contribute also to the forgiveness of missed doses are the design and the resultant better pharmacokinetics of some of our newer agents. I will not belabor this here, but I have shown this before. This particular graph shows that the dissociation half-life of second-generation integrase inhibitors, namely Biktarvy and dolutegravir here shown in green and red, is much longer than the dissociation half-life of the earlier first-generation integrase inhibitors, raltegravir and elvategravir. And that is basically due to the structure of the drug. But basically, this is telling us that it stays locked and loaded into its receptor much longer than the first generation drugs. The tighter a drug can fit, the longer it can stay there, the better chance we have of it being more forgiving if somebody happened to miss the next dose. And this is largely based on the chemical structure of the drug. Not only do we want forces built into the drug to help it lock and load into the receptor, but we want structures like bicyclic side chains shown here with bictegravir, for example, to actually help that drug become flexible in the active site. So if the active site somewhat changes due to resistance mutations happening, the drug's ability to stay static in that particular receptor, built with a little bit of built-in flexibility to move around resistance, helps us have a better forgiveness of doses missed of that particular drug. And we have seen this before. I'm showing you here the second generation darunavir, protease inhibitor darunavir, just by adding a simple chemical structure like this bicyclic ring, changed it so significantly from its first generation precursor amprenavir that it stayed locked and loaded into the reactive site 100 times longer, meaning that its ability to stay in the site and become flexible when things change within the site of protease is much greater. And so therefore, things like darunavir and these second generation integrase inhibitors are what we say have a high genetic barrier to resistance. I hope that helps explain things a little bit better. So if I were to sum things up, antiretroviral design should be simple, potent, and forgiving. The word pharmacofragility describes the consequences if an ART regimen's durability predictors are not met. For example, a regimen would be more difficult to take or less potent, less forgiving, would be far more fragile, and the resultant viral breakthrough would be the consequence of resistance developing. We basically want to build a house of bricks for our patients when it comes to their regimens. A good friend of mine, Dr. Bluma Brenner, excuse me, introduced me to this analogy and reminded me of the story of the three little pigs. Sorry. Considering ART is for life, to build a house that withstands the big bad wolf pressures that can happen with a regimen when life happens and pills get missed or lost, etc., is extremely important. To put it another way, modern changes in therapy or modern starts in therapy should build a house that's resistant to the development of resistance. And this is true whether it's the first regimen or whether we're switching or modernizing or moving to a new house, so to speak. All potential for that regimen to become fragile must be taken into consideration. And it's our clinical duty nowadays to be able to inform our patients not just about what the new and improved therapies are, but also how they will perform and what would be the consequences if they stopped performing. So before we conclude part one of our exercise, I'd like to cover our next objective and just introduce you to the various assays that measure antiretroviral resistance. We first need to understand and define the terms genotype and phenotype. The genotype is an actual picture of the structure of the portion of the HIV genome that codes for the production of protease, reverse transcriptase, and integrase enzymes, shown here in the pole region of the genome, highlighted in green. So basically, what you do is you look at they've sequenced this particular region, and it's about a 500 amino acid sequence, and they know which amino acid code is at each particular position in that pole region in the wild type virus. When they come across a mutant strain, they then therefore map out the pole region of the mutant strain, and they look for changes in that particular, in that 500 amino acid sequence at whatever position, and then they see what is that actual change, and this is how they code it for resistance. So in a genotype report, you see something like this. Hopefully this will make things a little bit more explanatory. The arrangements of numbers and letters tells us that at position 184 of the pole region that codes for reverse transcriptase, 500 amino acids, there's been an amino acid substitution. Basically, where in the wild type virus, we would see AUG, which codes for methionine, is now changed to GUG in this mutant version, which codes for valine. This is why we call these mutations the M184V mutation, because it mutated from methionine at position 184 to valine. Now we kind of get rid of those first letters, and most often you'll hear people talk about a 184V or a 41L, and we don't usually put in that first letter. But this is really how all genotypic changes or mutations are reported. Interpretation of these mutations requires an experienced practitioner with a knowledge of which mutations signify a reduced phenotypic or clinical response. Many earlier studies validated the use of resisting testing as standards of care for HIV, but it is widely accepted that there's a greater validity with expert consultation. So, because of this, experts created various algorithms, and they have been set up to help us not so expert people become a bit more expert in interpreting these results. Commercial assays will give an interpretation as to the virus's susceptibility to all agents. The following is an example of what one of these reports might look like. This is an earlier version of a genotype report. What you can see is you see the tabs on the left are the classes of agents, then the individual names of the drugs that are in those classes. NNRTIs and NRTIs are the mutations that are shown that will confer resistance to those classes of drugs. You'll see that the mutations that are the most important to you to be looking at are listed above the names of the drugs. So this 41L, this 44D, this 67N, these are the mutations in this particular report that have conferred resistance that you're seeing reported here. Same with the NNRTI, it's also mutations that are going to affect reverse transcription. Then down below in the PIs, you see the PI mutations, and this is now a similar place. You're going to look above the names of the drugs in this report. I show you this other report because this is more common what we get now, and this is, I just want to show you that the actual number of mutations that you're looking for actually appear below the list of the drugs. Still, you're looking at the NNRTIs and the NRTIs, and you're looking at the PIs, but you're looking below the list of the drug names to find these numbered mutations. I just want to point out something here under the NNRTI mutations. So the second arrow listed here below, you're going to see something called a 108I/WT. Whenever you see that on a resistance report, it means that somewhere the 108I has either been formed and is reverting to wild type WT, or the wild type virus is now evolving to a mutant strain 108I. Regardless, it means that the 108I is either happening or it has happened. And like I told you before, to edge on the side of caution, we count that as a 108I mutation when we're doing our homework. So it means that there's been either wild type converting or going back to wild type. But in my book, to keep things as strict as possible and to uncover as many possible problems as possible, we are going to count that as a 108I mutation. I only threw that out here because this is the best place for me to explain what that question that might come up from that. To end things off, a phenotype is basically just looking at the function of the HIV. It literally takes the virus, sometimes now genetically manufactured in laboratories, and actually subjects it to various concentrations of drugs. And the phenotype is actually looking, just like in micro lab when we used to Petri dish discs, it's actually looking at concentrations of drugs that we know will kill the wild type virus and comparing the concentrations necessary to knock off a more resistant virus. And that is reported as a fold change. So, for example, if an M184V mutant virus was grown in a test tube of cytosine analog drugs like lamivudine, you may need like hundreds of times more drug in order to get the same level or 50% suppression of the viral growth that you would with wild type. So that would be considered a highly resistant mutation. So this is what a phenotype. In a perfect world, if everybody could be phenotyped, everybody's virus could be phenotyped, it would make our decisions so easy. But that's not financially possible. So databases were made from phenotypic tests to predict resistance. For example, that 184V virus, if it is present in that particular test tube, you would therefore predict that any virus carrying this mutation would behave the same way and be resistant to the same drugs. So that is why, for all intents and purposes of this ART Resistance 101 exercise and the next part 2 and part 3, we will be focusing on a simple way to gather mutation information and use algorithmic tools designed to make this easy for us to make these predictions. So, I hope you will join me for part 2 of this exercise, in which we will do exactly that. So this includes part 1 of tackling antiretroviral resistance. Thank you so much for your attention. I hope you enjoyed it, and I hope I see you soon for part 2. Bye for now.